This is Status of States, where we explore health and healthcare across India's diverse regions with a particular focus on policy programs and ground realities. The Indian Constitution lists public health as the responsibility of states. Join us as we speak with health experts from different states, understanding the unique contexts, challenges, and innovations shaping public health. I'm Shivangi Rai, your host for this episode of Status of States, brought to you by the Center for Health Equity, Law and Policy at the Indian Law Society in Pune. Let's dive right in. In this episode, we explored the state of Tamil Nadu. We are pleased to have with us Dr. T. Sundararaman. Dr. Sundar is the former Dean of School of Health System Studies at the Tata Institute of Social Sciences. He was the director at the State Health Resource Center in Chhattisgarh and also the executive director of the National Health Systems Resource Center. He has played an advisory role in formulating public health policies in several states and had a major role in the design and implementation of the National Rural Health Mission, especially the ASHA program, the Mitanan program, and the Health Technology Assessment program. Dr. Sundar was the chairperson of the Technical Advisory Committee of the Health Technology Assessment Board for 6 years and is currently the chairperson of the Advisory Committee for the Chief Minister's Comprehensive Health Insurance Scheme in Tamil Nadu. Dr. Sundar, Tamil Nadu is often cited as one of the top performing states in public health and some social determinants as well. The indicators related to life expectancy and health, as well as determinants of health such as literacy and education, clean drinking water and sanitation, are better than the national average. Can you tell us about the health and related indicators where Tamil Nadu has been performing well?
So, Tamil Nadu is indeed one of the best performers in the health sector, not only with reference to other states in India, but also with respect to most other low and middle income countries. It has been cited as an example of good health at low cost. The most well-known achievement of Tamil Nadu is with respect to its performance in maternal and child health and in family planning. It has a crude birth rate of 13.8 and a total fertility rate of 1.4, as compared to all India figures of about 20 and 2.0 respectively. That is, it has achieved a shrinking population. Earlier, its sex ratio was worrying, but by 2011, it had stabilized. Its maternal mortality rate is 54 per 1 lakh live births. That is, in about 7.24 million population, there is only about 575 deaths in the whole state. The state aspires to lower it further to 100 deaths. And indeed, if any state can do it, Tamil Nadu can do it. Tamil Nadu is known that if its administration sets its mind on an objective, both the general administration and public health administration, being remarkably capable, would achieve this goal. Infant mortality rate is 13 per thousand live births, less than half of India's 28 per thousand live births. Quite remarkable. Under 5 mortality rate is 13 compared to all India figure of 32 per thousand live births. And the rate of decline has been good or better for most of these indicators than the all India level. The Tamil Nadu did so even without the favorable social determinants that marked Kerala's achievement, is something that drew attention to the health sector's performance. But this is not to belittle the fact that some of the most common social determinants in Tamil Nadu, too much behind Kerala, are well ahead of the rest of India. Tamil Nadu has done much better on the important proximate social determinants of health, especially those of immediate relevance to maternal and child health. There's nutrition, drinking water, sanitation, and female literacy.
The progress in many indicators and outcomes in health and some social determinants is indeed remarkable, as you put it, Dr. Sundar. So, what are the factors responsible for this good performance in public health and social determinants? In particular, how was Tamil Nadu able to reduce infant and maternal mortality rates? Please comment on factors, policy programs, or practices that you think have contributed to this good performance and can be replicated in other states or at the national level.
I think for this performance, which I have described, I would attribute three more main reasons. There are many, but I'm just picking up on three. First and most important is for the last few decades, Tamil Nadu has had a strong articulation of social justice. And this has led to a much greater emphasis and performance on social determinants related to nutrition, drinking water and sanitation, female literacy, and affirmative action to ensure access to maternal and child health services. Remember, Tamil Nadu was one of the pioneers in the midday school meal program, and it had universalized this at the ICDS much before it became part of the national agenda. It provides one of the highest levels of maternity support that any state does. The second reason is the much stronger tradition of public health in the state, notably the existence of a Public Health Act dating back to 1939 and closely associated with it a Directorate of Public Health and a Public Health Cadre, a set of combination of factors that very few other states have. This provides a professional capacity which few states have had in the first 5 or 6 decades, and you can see that it will deliver what it promises to deliver. And this leadership means it takes pride at the local and state levels in their performance. And finally, there is a relatively good administrative capacity, both the general administrators and technical leadership. I would say with some confidence that if the administration leadership, if convinced of a societal outcome, either due to its internal process or due to political leadership, then it will get there. By the same token, what it has not done is also the lack of conviction amongst the leadership of that goal. And seldom is it an implementation failure.
Clearly, there are some good strategies there. Some of it definitely has been replicated at the national level, where there is guidelines on public health cadre and definitely pointers for other states to also institute some of these strategies. Dr. Sundar, though Tamil Nadu has performed very well on these health-related indicators, there are many indicators where there is a growing challenge, and Tamil Nadu is not doing so well. Could you talk about the main challenges faced?
The main challenge that Tamil Nadu faces is with respect to non-communicable diseases. Over 60% of all mortality is due to non-communicable disease. And of this 60%, below the age of 70, what is referred to as preventable or amenable mortality constitutes the major part. There is also a huge excess male mortality across all age groups below the age of 70. Contrast it with a high-income country where only about 30% would be below the age of 78. You can see the difference. Other major challenge is the high mortality due to injuries, of which road traffic accidents accounts for the major part. About 14% of mortality is due to this. In contrast to the very weak program on NCDs, the state has a very robust program on prevention and response to road traffic injuries, but that is not enough. Also, there are challenges due to self-harm or suicides, assaults, drowning, gender-based violence that are relatively less addressed. There are new challenges in communicable diseases, especially acute respiratory disease and the old challenge of tuberculosis, which together, along with diarrheal outbreaks and rising antimicrobial resistance, makes communicable diseases still a major contributor to mortality. So I think these are the main areas where the state is challenged. There is a set of unfinished tasks on reproductive and child health. There is a difference in the achievement between districts and issues related to anemia, malnutrition, postnatal care, etc. But these unfinished tasks should not be used as an excuse to refuse to budge from treating the primary health care as if it's only a maternity care system. Let me see why I say this. Let me give you some figures. In 2023, there were relatively about 6.9 lakh deaths by both global estimates and by their own death reporting system. Of these 6.9 lakh deaths, 3.87 lakh deaths were below the age of 70. That gives a high probability of preventable deaths, about 60%. This would compare to less than 30% in most high-income countries. And of 3.87 lakh deaths, more than half or 2 lakh deaths could have been reduced by good access to comprehensive primary health care. And of these 3.87 lakh deaths, only 11,000 deaths could be due to maternal or under 5 deaths. So while the system has done remarkably well with respect to the causes of 5% of deaths, it has not done very well with respect to addressing 95% of the causes of mortality and morbidity. And to my mind, the reason is that the political and administrative leadership are yet to come to grips with their need to do so. The poor coverage of the entire disease profile is also reflected in the challenge of rising out of pocket expenditures and impoverishment due to healthcare expenditures. Despite a wide network of public services, a high degree of incomplete service delivery remains. I must also point out that public perception of the effectiveness of Tamil Nadu's public health system is in line with these figures. A recent CESP well done survey after the parliament elections showed that only 26% of voters were satisfied with the health services as compared to an all India 39% and above 50% in some of the states. And this correlated with voters who held the state government responsible for health services and also held health as an important electoral issue. Clearly, the poorer perception of healthcare in health services in Tamil Nadu is related to better health awareness on part of the average Tamil Nadu voter. But that is only to be expected. Why I say this, I really hope that the leadership has noticed this too and is not too lulled into complacence by their rather good achievements in infant mortality and maternal mortality. They just have to move on.
To me, this is surprising. After all, in Tamil Nadu, almost 63% of the state's population choose public facilities when a household member is ill, which is higher compared to other states except for Kerala. Of course, there are district level variations in this, but overall, does not Tamil Nadu do much better? What are the issues with regard to access to primary healthcare services then?
Overall, it is true that access is better in Tamil Nadu. But there is, as you have pointed out, a high inter-district variation, ranging from, say, 42% in Kanyakumari to 82% in Nilgiris. But then it is also pro-equity, which means that the poor are more likely to seek care at public facilities. 86% of households in the poorest wealth quintile typically seek care at government facilities compared to 27% of households in the richest wealth quintile quota source. And rural households are more likely to use public service sector also. So all this is good. In terms of progress in physical infrastructure and establishment of facilities, the gap in rural areas in primary care is minimal. But the gap in urban areas is huge. And we must remember that currently close to 50%, about 48% to be precise, of the population now live in urban areas. Thus, in most rural areas, we would expect one primary health care for 30,000 population and 6 sub-centers under each 30,000 population, each of them creating to 5,000 population. In urban areas, in contrast, each primary health center caters to 50,000 population and there is a 34% shortfall in primary health center and there are no sub-centers for each for 5,000 population. And the health posts or dispensaries which are there have little primary care orientation. So most of the primary care needs of the urban poor are met at medical college hospitals, which as a result are hugely overcrowded, making access to the poor a nightmare, while compromising quality of primary care as well as compromising the quality of secondary and tertiary care these provides. So Tamil Nadu in a sense recognizes this and its expansion of medical college hospital depressurized these needs. But this is no way sufficient or a substitute for expanding primary care services. That's what is reflected in much of the data. This hurts most in access to primary health care for non-communicable disease and indeed for all non-reproductive and child health services. Thus, of the 3.87 lakh premature deaths, 2.4 lakhs or about 63% of male, and this is an excess of 1.16 lakh over the number of female deaths, meaning there are 1.16 lakh more male deaths than female deaths. we can see that this problem is affecting the working population most, and among them, largely younger working men. We know that the state has introduced a program of monetary payment, sort of subsistence grants of rupees 1,000 per month to single women headed households, and spending a few 10,000 crores on this layout, which is welcome. But a proportionate sum invested in primary healthcare would have reduced this requirement considerably. In some age groups, the excess male deaths could be almost thrice the female deaths. Closely related to this is that Tamil Nadu has one of the poorest transitions to health and wellness centers. Not more than one third of its targets have been reached, and in terms of functionality, it's even less. This health and wellness scheme is the scheme for moving from the earlier selective care focused on reproductive and child health to comprehensive health care where NCDs constitutes a major part. And Tamil Nadu, unfortunately, lags behind. Its primary care system, I'm afraid to say, is no longer quite fit for purpose.
Dr. Sundar, you have very substantially made the point that Tamil Nadu needs to expand and strengthen urban primary care and galvanize its efforts to transition to comprehensive primary care, which are essential for completing the unfinished agenda of reproductive and child health, to effectively address the persisting and resurgent communicable diseases, and to address the rising challenges of non communicable diseases. With respect to closing the gaps in accessibility and availability of health services, what strides are schemes like Makal Tedia Maruthuvam, which translates to medical care reaching the people, making?
I would rather see Makkal Thediya Marutvam sort of as a hesitant baby step, a token of awareness of the huge problem of NCDs, falling short of the effort required to achieve the necessary results. This scheme reaches medication for two or three common non-communicable diseases, hypertension and diabetes, to the subset of patients who require it. And this has received, no doubt, a huge welcome given the big gap. Even it reaches some peritoneal dialysis fluids and some pilot modes. But this is falling far, far short of the required effort. To understand the effort required, compare the current Tamil Nadu arrangement for these services with what is envisaged normally for the movement to comprehensive healthcare across the nation as the normative recommendation. The best performing subcenter in Tamil Nadu would be catering to a 5,000 population with two staff, one A&M whose duties are relatively related to RCH, and one woman health volunteer with minimal training and support who is in charge of the NCD dissemination. But the norm for a subcenter upgraded to health and wellness center in the national level is to place one community health officer, that's a mid-level healthcare provider, one or preferably two A&Ms, one male worker, and at least five ASHAs. That means at the national level, you have 8 frontline trained health workers as compared to Tamil Nadu's 2. Tamil Nadu refused the ASHA program, taking on the high moral ground that they would go only for regular workers. Now, the woman health volunteer they have brought in is a contractual worker who is overloaded and undertrained and under-remunerated as even compared to the ASHA. And Tamil Nadu no longer gets the ASHA remuneration either. And Tamil Nadu increases its contractual workers across the board and goes slow on its regular frontline appointments. I am hesitant to say this, but I think Tamil Nadu's reluctance to invest in the primary healthcare workforce is leading a shameful setback for what once was the leader in primary healthcare. No longer is Tamil Nadu punching about its weight. Its performance is sort of par with its GDP, but nothing more, and is in danger of falling behind. People's perception on this gap has been more acute than that of the administrator. The paradox is that Tamil Nadu was among the first to pilot the community health officer and the health and wellness movement. And the feedback from prompt evaluations, which the Tamil Nadu government itself had ordered, showed a remarkable improvement in the functioning of sub-centers. But due to reluctance at senior administrative levels to sanction that increased staff and the cutbacks on commitments to health and wellness center upgradation, a really unacceptable retreat occurred. An expert committee on health policy did call for such an expansion of the primary healthcare workforce, but it's been on the shelf along with other expert reports. All of this means that most primary care services, people are having to go to the private sector with high out of pocket expenditures, and they come to the public sector only when their simple community level manageable problems of hypertension and diabetes have escalated into near fatal coronary artery disease, strokes, renal failure, and chronic obstructive pulmonary disease has led on to respiratory failure. So this is really a challenge of why I said the primary care system is becoming unfit for purpose or needs to be made fit for purpose, to put it more positively.
It is indeed paradoxical and a little disappointing that having pioneered the initiative of community health officers and having the evidence of its effectiveness on the ground, Tamil Nadu is still choosing not to put in place the necessary and expanded workforce for primary care. Extending the concern about human resource issues to secondary care. As per the latest Rural Health Statistics report, which came out this year with the title of Health Dynamics in India, Infrastructure and Human Resources, several states, including Tamil Nadu, have up to 80% shortfall in specialists at the community health center level. Why do you think this problem is persisting, and what measures is Tamil Nadu taking to fill this gap? What do you think of the initiative of the Diplomate of National Board, the DNB course as it is called, in district hospitals under the National Health Mission as a means to rectify this shortfall?
Tamil Nadu has done remarkably well in expanding its infrastructure for secondary healthcare, and this includes the human resource at the level of specialists. It has done very well in expanding the availability of specialists and specialist provided services in the public sector, both in the district hospital and in the district medical college. So, one part of the strategy is to opt for a medical college in every district. I am not fully convinced that Tamil Nadu needs to be producing so many doctors, but I am very sure that the government has correctly perceived and responded to the increased requirement for access to entire range of secondary and tertiary care services within a district. Only quaternary care, and I'm aware this is a new term coming into vogue, it needs to go to state level centers of excellence. Meanwhile, it has also strengthened its district hospitals, upgrading taluk hospitals to district hospitals, where district hospitals have become medical colleges, as well as upgradation of most taluk hospitals. It could do better within CHCs, but given Tamil Nadu's huge improvements in road connectivity and modest improvements in patient transport systems, we could overlook this, not bother too much about the national document comment on CHCs in this regard. In closing the specialist gaps, Tamil Nadu has been richly rewarded for its policy of reservation of 50% for in-service doctors, along with compulsory post-graduation bonding and other incentives. This entire arrangement has been threatened by the Medical Commission of India, their whole push towards the NEET exams and the next exams as it was for entry into medical and postgraduate education. Despite it, at this point of time, thanks to the legacy, they are doing very well on that. And I don't think very few other states would have this level of better performance. Tamil Nadu has also pioneered the introduction of DNB programs and family medicine programs to better provide skills at the CHC and PHC level also. They could take this up to scale with a greater commitment. But on the whole, this has not been their, they're doing quite seized of it and doing well. There are, however, persistent gaps in nursing and support staff, where Tamil Nadu government's proverbial reluctance to have public employees comes in the way. But I would say, to some extent, that directorates are seized of this and they are in some efforts to address this issue rather more successfully than they have been able to do for primary health care. Tamil Nadu also has long back successfully addressed the problem of logistics and supply chain management to ensure uninterrupted consumables and supplies to the public hospitals. In addition, it now has the CMCHIS, the Chief Minister's Comprehensive Health Insurance Scheme, kicks in, providing the medical college hospitals with enough flexible funds for upgrading to a higher, more technological demanding care. So, in terms of design, I think the secondary and tertiary care is much more fit for purpose than the harsh comments I had to make about primary care.
It is good to know that efforts are being made to fill the gap in human resources, and we hope that measures such as reservation in postgraduate courses for doctors who have served in rural areas and emphasis on DNB and family medicine courses will go a long way in augmenting human resources for public health services. Dr. Sundar, you mentioned that Tamil Nadu has improved its logistics and supply management for drugs and consumables. What are the mainstays of the procurement and distribution policy, and should it be replicated in other states?
This policy actually came into being in around the mid 1990s, and it's a global model. By the turn of the century, they also had the Transparency Act. The policy came much before the legal support. What it does is make entire procurement completely transparent and completely responsive to needs without having any space for political or vested interest intervention at any level. Also built a very, very robust system of quality assurance where the labs that test for quality assurance are already tendered and inspected, and samples of every supply is sent to them, and only with their approvals payment is made. So it's a whole set of processes that have been put in place and a separate institution that functions with an extraordinary degree of efficiency. The cost of administration of this system is less than 2% of the cost of the supplies that are provided. Are the mainstays of the procurement policy. Can it be? It has been replicated in a few states, Rajasthan, Kerala, to some extent Meghalaya more recently, but largely not in other states. And the reasons are not good because there is the largest vested interest lies in procurement. It's not quite geared to the newer challenges. But having said that, I think this is really one of the strengths and has been helping. It's not yet geared to certain areas like the outreach of health and wellness centers, but it will get there. I have less concerns regarding its procurement and supply system.
Access to medicines in the public sector, affordability, and out of pocket expenditure are significantly affected by the efficiency of the drug procurement and distribution systems. And we do hope that more states can strengthen their procurement systems and allied policies like Tamil Nadu has done. Moving to the issue of government funded health insurance programs, what do you think is the role and limitations of insurance programs in achieving health for all, whether it be the Tamil Nadu Chief Minister's Comprehensive Health Insurance Scheme or the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana?
So both these schemes are integrated in Tamil Nadu. The CMCHIS, or the Chief Minister's Comprehensive Health Insurance Scheme, is a state-sponsored health insurance scheme targeting families with an annual household income lower than 72,000 and providing cashless coverage for an explicitly defined package of diagnostic secondary and tertiary care providers to a maximum of about 5 lakh rupees. The scheme covers about 62% of the population. That's a very good coverage. And per year, it pays for some 6.9 lakh therapeutic procedures and 2.19 lakh diagnostic procedures, with 50% or more of the claims going to the public sector and about the same amount of claims, a slightly higher amount in value of claims going to the private sector, but about the same equal divide, which compared to other states is quite a achievement. It does have a architecture to provide financial protection. Its main challenges are that obtaining a card remains a challenge, and that it affects the poorest quintile more is a thing that the state is seized with. Second, which is less able to do something about, are that budgetary constraints seriously limit the scheme, and a premium of family that they are paying for, government is paying for 842, is minuscule compared to what most states are paying at about 2,000 to 3,000 per family in each state. And it's really about rupees 10,000 in private health insurance. So therefore, a whole lot of the services fall outside the range of coverage for one reason or the other. And at sometimes the insurance company, to keep within its budgets, also becomes unduly tight on what it sanctions. And therefore, there's a lot of rejections. Leads to a lot of dissatisfaction. Third, only some of the services are open to the private sector. A few private hospitals are empaneled. All public hospitals are always empaneled. And therefore, locating a provider is a huge challenge. For not all public hospitals provide all health services. And fourth, government medical colleges may deny treatment without a card. I mean, this is not at all permissible and they know it. But remember that since all these hospitals are anyway overcrowded, there is some sort of arbitrary rationing that is inevitable. And absence of a card becomes a disadvantage to the access and to the provider. And finally, the big problem is that when it comes to the private hospital, enforcing cashlessness or even a reduction beyond the nominal discount has been next to impossible. And therefore, catastrophic health expenditure. So, efficiency of financial protection in the private sector is very poor, and in the public sector, it is good. But the public sector, it's a top up finance. However, on the positive side, this scheme has helped build up mechanisms for engaging with the private sector, and with better gatekeeping and monitoring, it could play an invaluable role in universalizing access to secondary care. It could also be a form of ensuring adequate, requirement responsive funding for public hospitals. And therefore, in the movement towards universal healthcare and the right to healthcare, this is a scheme I would say is an invaluable step forward, though it's very much a work in progress.
It is notable that presently the number of cases being referred to the public and private empaneled hospitals at the secondary care level under the health insurance scheme is almost equal. It is different from some other states where most of the cases are being referred to the private empaneled hospitals. The concern with that being that public money is funneled into private sector service provision, resulting in the weakening of the public health system in the long run. Dr. Sundar, the Niti Aayog had issued a concession document in 2018 advising states to lease out district hospitals to large corporate hospitals to manage them and provide health services. Is Tamil Nadu implementing it? And what do you think of this policy direction taken by Niti Aayog? How is it going to impact access to affordable health services for the people?
Fortunately, Tamil Nadu has not taken that route. Much to Tamil Nadu's credit, its officers have a pride in running its public health hospitals well, and its directorates have the competence to do a good job. They do a good job. Except to some extent at the CHC level, there is no underutilization of capacity, rather excessive utilization. In fact, I don't think this is a solution anywhere, though in Tamil Nadu they are not even looking at it. Even in other states, there is no pressure from the public or even from the state government to outsource its district hospitals. This leasing out is done more to bail out private medical college who charge huge fees but are unable to secure a patient load to teach their candidates. And district hospitals provide access to the poor and sick for teaching purposes. It's a very cynical way of doing it, but that's been so for a long time. This pressure to lend the district hospitals to the teaching requirements of private medical colleges which charge exorbitant fees is present even in Tamil Nadu. But it is the CMCHIS that assists the private medical colleges in being able to use their marginal capacity. Their marginal capacity may be 60 to 80% of beds, and rather than the outsourcing of public hospitals. So at least this is not one of the problems that Tamil Nadu is faced with or a direction that it seems to be taking. And that risk is always there.
Thank you for your response, Dr. Sundar. Moving to the area of communitization in health. How strong is community participation in health services in Tamil Nadu? What has been the role of village health sanitation and nutrition committees, Panchayati Raj institutions, and civil society in health planning, implementation, and monitoring?
Well, unfortunately, Tamil Nadu is not a leader in community participation at any level. As I said, it's a state with a great confidence and competence in its administrative abilities. And it really hasn't quite recognize the role of it. Yet, this role is extremely important if we are to address challenges or inequity, and we have to recognize and acknowledge challenges of inequity. So, the good news is that there has been a change in recent years. In the last 3 to 5 years, the state government has actively taken up the organization of health assemblies at the state level, at the district level, and in some of the blocks. In this, it has been inspired by the model from Thailand, and it has been inspired by earlier experiences in community based monitoring. And it's been doing well. There's been a very good response. A whole lot of gaps pertaining largely to infrastructure has been flat in these meetings. And quite surprisingly, even junior government health employees are some of the most active participants in these assemblies, using the occasion to point out gaps in their facilities which need to be covered. Tamil Nadu's achievements in village health and sanitation and nutrition committees, I would rather not talk about. Its panchayats have been involved in the district health assemblies very well. But as a rule, it has had a much more limited role to play in public health management. And its civil society role is also very limited. There are very good not for profit hospitals, but except for a few hospitals, even survival within the CNCHS scheme for them has been very difficult. I think there's a lot more that can be done in this area, especially both in the transition to more non-communicable diseases and comprehensive primary care, and also a sort of grassroots awareness and accountability that is not of a contestational form, but is of a complementary form. For example, preventing irrational consumption of medicines, because it's a public system where the market is not limiting. Then you need both community-based systems and much higher degrees of non-market-based interventions to ensure that some of these problems are limited to be responsive. So I think there is a much greater role to be played, and it can learn more. But the good news is it has made a start. I hope it continues. I mean, very often, since they come through with great difficulty, they may not sustain unless there is some championing of the initiatives that have been working.
Well, turns out that Tamil Nadu is the first state in India to adopt a participatory health governance model through an approach of organizing health assemblies at the village, block, district, and finally culminating at the state level. It is, however, a new initiative, but we hope that it will be effective in strengthening community and civil society voices in health planning and improvement. Dr. Sundar, are there other best practices in Tamil Nadu beyond its successes in reproductive and child health that you would like to highlight?
Well, there is one which I think bit early to say what is the eventual outcome, but I'm reasonably sure it is going to lead to a big change. I think it's something that countries should follow. I'm particularly impressed with what is called the Innuir Kapom Nammai Kakum Napatti scheme. That's a tongue twister for anybody who is not Tamil. Basically, it means life-saving 48-hour scheme. What it means is referring to the entire scheme on road safety and road traffic accident injury response. So we started earlier by saying that in terms of mortality, this is second or third highest cause of mortality. So you have cardiovascular diseases first, and then you have either communicable diseases or you have road traffic accidents, which are the second highest cause of mortality. Of course, if you were to include morbidity rather than mortality, road traffic accidents will fall to the much lower, because there is, by definition, no morbidity available with it. You have an accident and that's it. I mean, you have an injury. Road traffic injuries is really the big issue. So what has this scheme done? This scheme has gone about it very scientifically. It started with a dynamic identification of hotspots, because accidents, injuries are concentrated around some high spots. It has led to a dynamic allocation of ambulances so that they are more dense where the hotspots are more dense. There is a mapping of ambulance to both hotspots and emergency care providers, leading to very effective district level plans. There is a scheme for pre-arrival intimation of the emergency care provider that a sick patient, injured patient is on its way. There is a development of a network of 692 emergency response hospitals, of which 237 are in the public domain and 455 are private providers, with reimbursement of expenses of care for all the private hospitals in agreed to terms under the MOU, with very little complaints. And these hospitals are categorized into level 1 to level 3 of emergency response management, paid accordingly, and referred patients accordingly. So, very often these emergency ambulance systems are now relatively universal, but not the emergency response hospital systems. This system is expected to have saved close to 1.86 lakh lives since it's in place. It saves a huge amount of lives, and it's about 163 crores spent, well spent, I would say. Along with this, they are working on a task force on road safety. It turns out there are 14 to 15 different department authorities who have to coordinate to reduce the accidents in these places where it happens. And therefore, road safety laws, road safety policies, road safety implementation. So, there is a huge effort going on into the prevention of road safety so that there is a decline. Of course, given Tamil Nadu's geometric expansion in the number of vehicles on the road and its roadways, whether it will still lead to a net reduction is open to question. But it is no doubt quite well planned, a very scientific planning where in a systematic way they have sort of mapped a problem and put their deployment to it, systematically showing results on it, looked at it holistically. I think this is not only a very good example as a practice in road safety, but even in how public health needs to be practiced.
As we discuss the successes, challenges, and unique initiatives in health that Tamil Nadu is undertaking, I would like to also discuss the issue of the health budget. Similar to national trends, government health spending in Tamil Nadu has been quite low, representing only 1% of the state's GDP. Although it is remarkable that Tamil Nadu has consistently produced better health outcomes with the same average per capita expenditure on health as India, and probably a little lower than India. But do you think it's time for the government to increase its health budget?
Certainly, I think it can afford to double its expenditure on healthcare and invest this largely in public health facilities. And within that, in human resources, where it is its greatest reluctance. Unless you have more feet on the ground, you're not going to get more services with just consumables. So it does require a much greater investment. Tamil Nadu can do so. It has the fiscal space to do so. Its GDP per capita is one of the highest among states. But it can afford to improve the effect of what it spends. There is efficiency to be great. So it can afford to improve that effect. One way of doing so is to merge the risk pool of government expenditure on health from the state government with the ESI and the government servants insurance programs so that they complement and do not overlap and substitute each other so that they do not duplicate. You can actually get a much larger set of providers and risk pools into play. But I also think there are some more efficiencies to be gained in the way in which care is streamlined so that people are able to save their time and effort and their money in shopping for the right provider. But that's more on the societal side. For a government, therefore, it has ambition to be a 5 trillion economy. But the purpose of such an economy should be improved healthcare. Why else would you want to be wealthy if you're not interested in making use of that? And also, when you are increasing productivity at such a big scale, then health of people is an important type of investment. Much as we are willing to investment in roadways and highways and power plants, which also takes 20 years to break even. Healthcare investments will also break even much earlier. So I think somewhere the economic value of investing in human resources for health should be seen as one of the most pro equity forms of public health expenditure that is possible for the state
and one of the most high return forms of public health expenditure.
There is a big way to go for achieving this in Tamil Nadu. Tamil Nadu can do so. I would add one more point. You know, when I was in Thailand and I was asking them what had motivated them, in the 90s, they had been motivated by Tamil Nadu's exam. In 2002, they passed the Right to Healthcare Act, and since then, they have gone far ahead. So that now their figures are comparable to the best in the high income countries, where the Tamil Nadu is just happy with being the best among the states of India. So, the reason that the Thais have gone ahead while they were on par with Tamil Nadu at one point is really because both their right to healthcare laws and because they were willing to step up their public health expenditure in a way that Tamil Nadu has not been able to.
You mentioned that the Right to Health Security Act in Thailand and allied laws and policies help Thailand advance its progress to universal healthcare. It is a nice segue to the last question I want to put to you. That is, what is the situation with regard to any movement towards a right to health law in Tamil Nadu? Can we expect Tamil Nadu to set a leadership role in this regard?
I wish so. I wish they see that they are at a level of economic development which is more than what Thailand was when it adopted the Right to Healthcare Act. I think Tamil Nadu has the entire architecture and the technological competence and the capacity it needs to bring about right to health and healthcare. It's there in every way. It has the finances, it has the technical competence, it has the experience to do so. Further, the right to healthcare is a subset of right to health, and right to health is a set of underlying determinants of health. Tamil Nadu has the oldest act in this regard. The Public Health Act of Tamil Nadu in 1939 is a very live act, been modified and amended much, which places a considerable burden of accountability on local bodies and has been an impact on model for other states also. And it has had 13 amendments after its first promulgation in 1939. It provides for addressing the health determinants, underlying determinants. It's somewhat, in practice, become more urban oriented, which is not a problem, but we need to have some better implementation in rural areas. But also in urban areas, it's much more about, because it's a colonial act, making the citizen accountable to the state rather than the state accountable to the citizen. And that twist is required. A second strength is that Tamil Nadu enacted a Clinical Establishment Act way back in 1997, and after a huge delay, placed the rules in 2018. Now, this is a very sad story. The act is very poorly implemented, but a space has been created to address the issues of regulation in the private sector. So when we propose a right to healthcare act, it does not bring private sector regulation into it because there is a separate act which should be amended and strengthened, but that will take care of it. But it need not confuse the right to healthcare act. But a right to healthcare act is absolutely necessary. It is necessary since it has to be a way in which people know where their entitlement to healthcare lies. It should be through registration with a public care provider, a primary care provider, and then is navigated or provided support and facilitation to access through that port of entry, not only primary care at that level, but all the entire range of health, essential healthcare services that are required at every level. So there's access a gatekeeper for which to ensure, more like a facilitator, more like a guarantor, to ensure that the entire range of secondary and tertiary care can actually be also obtained with financial protection. And everybody is considered to have paid for this healthcare as part of the premium that is inherent in their tax based financing. Because, in some sense, a lot of the taxes are indirect taxes, and the poor also pay for it. So I think that basically we do have this necessity for people to understand and access their entitlements. And that brings a lot of energy and efficiency and value for money. What does it mean in practical terms? If I go to a public hospital and the public hospital does not have the capacity because it's overcrowded, then it becomes incumbent on the hospital to ensure that I am referred to another place where the necessary services are available, be it the public sector or a contracted in private hospital. You just can't say my time is up. So this informal rationing that prevails goes. And further, hopefully, it will ensure that this is sort of charged expenses, not budgeted expenses. That the care, like today, you reimburse providers for the care they provide. So after ensuring efficiency and rationality, you are ensuring that
The care that is provided through the public network and contracted in private sector is fully paid for. The kind of state is in a good situation to be able to do this.
are there moves to do so? Yes. I think this government is more seized with it and better seized with it than any other government. But it should learn from the Rajasthan and Assam acts and not rush into something that will just provoke the private sector and be non implementable. It should instead learn from the Thai example and see how this will actually lead to a greater efficiency in public expenditure. I think that way they are serious about it. I mean, like I keep saying about the Tamil Nadu government, they may hesitate, they may not be convinced. But if they are convinced, I really believe these are the only people that can actually deliver it on the ground. That is the unique strength of Tamil Nadu. It takes hell of a lot of time to convince these guys to take that risk. And that's part of the limitation of the fact that this is administrator driven and not fully political driven. Because then there is an inherent tendency not to take that leap of faith, not to take that risk. But if political leadership can push them into doing so, I think the Tamil Nadu government will develop delivery as good as the Thais or even better. Tamil Nadu can do it. It's about high time it did it.
With that, we thank you, Dr. Sundar, for your valuable time. There is indeed lots to learn from the laws, policies, and practices in Tamil Nadu, as well as from your vast experience, expertise, and insights on public health. Thanks for joining us for this episode of Status of States. Stay tuned for more such conversations. This is your host, Shivangi Rai, signing off.